rahmatullah. It's my pleasure to present this lecture in front of my senior and in front of friends and our colleagues. Our subject is a case report, the management of posterior cruciate ligament injury which associated with lateral collateral ligament avulsion fractures. Our objective is to highlight the posterolateral corner and posterior cruciate ligament anatomy. The second one is to highlight the biomechanical effects of these structures. And the third one to compare our study to a case study to the similar popular studies. And lastly, recommendation regarding management of this type of injury. Posterior cruciate ligament anatomy, this is considered as intra-articular knee ligament which is originating from the lateral surface of the medial femoral condyle to be inserted in the posterior surface of the tibia about 1 centimeter below the articular surface with two components, anterolateral and posteromedial bands. In this slide, we notice that the posterior cruciate ligament is tight in flexion and lax in extension, and this is explained the function which will be discussed in the next slides. The selected category of the posterior cruciate ligament showed that in flexion the function lost was not affected in the extension. Regarding posterior translation, also rotational stability and change in extension, but it changed in flexion. The posterior cruciate ligament in this slide also we are concentrating on the posterolateral corner structures, the most important, the lateral collateral ligament, okay, which has the two insertions, femoral at the femoral epicondyle, just proximal and posterior, and to the fibular head. And the second structure is the popliteus tendon unit, which originates from the posteromedial surface of the tibia to be inserted in the also lateral femoral condyle, just anterior and deep to the LCR. The third structure is the popliteofibular ligaments, which originate from the musculotendinous junction of the popliteus tendon unit to be inserted in the styloid process of the fibula. Also, this slide, which also concentrating on the what we call tripartite origin of the popliteus tendon muscle. This is insertion in the femur, and this is popliteofibular ligaments inserted in the styloid process of the fibula, and here the third insertion in the posterior horn of the lateral meniscus. And this is a radiograph of the knee epi and lateral, highlight these insertions of important structures. This is the lateral collateral ligament in the femur and in the fibula, and this is the insertion of the popliteus, and this is the lateral epicondyle. Studies confirm the function of popliteus muscle tendon unit as a resistant to the tibial posterior translation, varus rotation, and external rotation. So insufficiency posterolateral structures will lead to varus thrust gait and the sensation of instability, especially when the knee is extended. Patient with isolated posterior cruciate ligaments deficiency will not experience a knee instability, a major symptoms of knee instability. However, if this DCL is associated with an injury, it will be disabling and devastating injury. One of the most disabling is the posterolateral corner injury associated with posterior cruciate. Biomechanical studies that support our study case report. A German orthopedic was called Haher, which conducted study at 1998, and the results was revealed that posterolateral structures play an important role in full extension in intact knees. While in knees with lost posterior cruciate ligament, the posterolateral structures play important role in all angles of flexion. Another biomechanical study conducted by Sigwar at 2007, which showed the optimum isometry of posterolateral reconstructions at femoral side which was about 11 mm anterior and 2.7 mm proximal to the center of the popliteus tendon footprint. The third study conducted by Aspering at 2009, which shows that when we have two injuries to the posterolateral corner and BCL, BCL deficiency or posterolateral corner deficiency restore the knee to the laxity condition. That's meaning if we address only posterolateral corner without addressing the posterior cruciate ligament deficiency in surgery, this is sufficient but could not reduce the posterior to normal. Our case presentation briefly, 40 years old male patient who presented to clinic complaining of left knee giving away with difficulty of walking for 4 months duration. And the patient suffering began after fall down on the ground while foot is entrapped with feeling of immediate pain, swelling and inability to eat breathing. After that, the patient was managed by back slab and analgesic without any improvement, underwent operation without any documentation. After 1 month, the patient felt unsatisfied and uncomfortable about his condition, and he sought a medical advice in another hospital. More investigation has been done, including MRI, and he underwent another surgery also without any documentation or benefit to the patient. On examination, the patient was average built. He was walking with assistance of 2 crutches. Without crutches, the patient has the feeling of instability with varus thrust and hyperextension of the affected knee. Left thigh muscles was wasting on inspection, and there was a varus malalignment while the patient is standing, and anterolateral scar over the left knee measuring about 15 centimeters. After that, special test conducted showing posterior sac sign and quadriceps active test, which was positive. Varus stress test at 0 and 30 degrees flexion also was positive, about 3+. And posterior downward test was grade 3 positive. Dial test at 30 and 90 degree of flexion, more than 10 degree of tibial external rotation. This is the X-ray of the patient, which show the tibial vulgin fracture with displacement and rotation, and some scattered calcification, and there is another fracture in the patella with lateral displacement, but it's not our subject. And this is the fragment laterally, which displaced posteriorly. The other thing is there is calcification at the insertion of the posterior cruciate ligament, insertion in the tibia, and posterior translation of the tibia. And MRI of the same patient, axial view, which show the avulsed fracture, also the fracture of the patella. In this sagittal view, there is detachment of the posterior cruciate ligament at the tibial insertion with posterior tibial translation. Also, sagittal plan show the avulsed fragment with displacement. In this coronal view, we also notice the same fragment which is displaced laterally with fibrous union and lax posterolateral corner ligaments. Surgical intervention was recommended after discussion, the risk, benefits, and possible complication reviewed with patient and family. They elected for surgery and appropriate consent was obtained. He underwent surgery under spinal anesthesia, and antibiotics were given, and re-examination or re-evaluation under anesthesia was conducted, and a stress view was also done intraoperatively under fluoroscopic image, which show more diastasis and opening of the lateral joint line, implying this varus instability. Incision was anterolateral over the same anterolateral scar, removal of the fibrous tissue at the fracture site, and exploration of the fracture refreshment. And this is the fragment which was measured about 2 by 3 centimeters. And after that, anatomic reduction was achieved using temporary key wires. Then reassessment of the stability of the knee, which show improved coronal and axial, meaning varus and rotational stability was improved with residual laxity in the posterior translation of the tibia. Again, the fragment was reduced with anterior displacement and slight proximal displacement, according to the Sigward study relative to lateral condyle, their evaluation which revealed dramatic improvement of instability in 3 planes, coronal, axial, and sagittal. This is post-operative X-ray which show a slight proximal positioning of the fragment and slight anterior position of the fragment. And the management post-operative, the patient underwent a strict physiotherapy program with improvement. And lastly, at 12 weeks, the patient was started full weight bearing and allowed to start active range of motion. Why understanding this case is important? This is a rare case with a posterolateral corner avulsion fracture that should be documented as a case report. Searching on the network show one case similar, has similarities and dissimilarities. The similarities is the age of the patient is about, the similarities is considering the avulsion fracture, the same, and this is the MRI, but the dissimilarity, the patient was 13 years age. And this is was suspected for this age because the ligaments in children are stronger than in adults. The other thing that it's presented acutely and managed acutely, the third dissimilarity, the BCL was intact in this patient. The second thing that why understanding this case is important is shared posterolateral ligaments, corner detachment, and BCL injury renders it a complex case. And biomechanical effects of the BLC is important regarding associated BCL injury. How the current study adds to that knowledge? In our case, we found that a proper management of BLC injury, which associated posterior cruciate ligament injury, may be enough for non-athletic and low demand patients to reduce surgical morbidity and allow improvement in function. Regarding biomechanical stability, which is improved dramatically after anterior and proximal displacement, as Sigward study suggests. Our recommendation, we hope, for future study that evaluate lateral femoral condyle or epicondyle osteotomy to address the management of posterior cruciate ligament injury in patients who are candidate for surgery on cadaveric study. Thank you for attention.